This meeting is being recorded.
Okay, hi. Great to see everybody. For those who don't know, I'm Rabbi Jamie. Welcome and thank you. There's a couple more chairs there.
Putting next week, you want to.
Sure.
That means you want to escape the topic.
Escape the journals.
There's no. I mean, my journal, I'm sorry. I could open it. She did? Harry has COVID.
Really?
Harry? Yeah, it's always me, that's my grand.
Well, again, thank you, friends, for coming. As many of you, most of you probably know, so this is an ongoing series that we've been doing all year on having difficult conversations. The title of the series is Taboo Topics, and most of it centered around dying and burial, and we've also had other topics that we've introduced, like abortion. And next week, Rich Levine is going to talk about the Second Amendment, gun rights, and controversies around the Second Amendment in this country. But tonight, we are really thrilled to have, as a member of our community, as a dear friend, Dr. Barbara Morris, for whom this topic is personal in a lot of ways, and couldn't imagine anyone else to have the gifts and skills and experience to facilitate this conversation. So please do a full introduction of yourself,
Well, thanks for having me, everyone. I know many of you, but not all of you, so thanks for coming and thanks for the invitation, Rabbi. I tell people that the hardest presentations or conversations you have are with those people I know. I can stand up in front of 200 people and not get nervous, but in front of all of you, get palpitations. So you just have to bear with me. I'm a geriatrician by training, family physician before that. And as part of my work in geriatrics, I've done quite a bit of end-of-life care and palliative care. And as part of that, I became familiar with issues about medical design. And we are not tonight, to get it off the table, we're not here to talk about what happened to me. Some of you know, some of you don't. But we can talk about that later informally about what happens when clinicians are in a healthcare setting where their employer does not allow something that the state actually allows. And so I got trapped in that and have spent 3.5 years actually trying to recover from that. But that's not the topic for tonight, although I would be happy to talk to you about what happens if you haven't already heard the story. But for tonight, we're going to talk about medical design. I want to put that in context a little bit first. So we're going to start with the poem, Death. Then Almitra spoke, saying, "We would ask now of death." And he said, "You would know the secret of death, but how shall you find it unless you seek it in the heart of life?" Welcome. The owl whose night-bound eyes are blind unto the day cannot unveil the mystery. If you would indeed behold the spirit of death, open your heart wide into the body of life. For life and death are one, even as the river and the sea are. In the depth of your hopes and desires lies your silent knowledge of the beyond. And like seeds dreaming beneath the snow, your heart dreams of spring. That's by sure. So for tonight, I don't have any PowerPoint or any slides. I do want to welcome a couple of special people, not everybody special, but Ruth Curran, who I've worked with in several different situations, and she's now working with us in End-of-Life Options Colorado. And Cindy, where'd Cindy go? Cindy Kaufman, who many of you heard do one of these topics a few months ago now, about some end-of-life issues, who's also on the board of End-of-Life Options Colorado. So they're with us as We're going to talk about why this is a taboo topic, if you think it is. We're going to talk about what medical aided dying is, and some things about advanced care planning. We'll talk about the statute in Colorado, the process, and some of the challenges. And then actually what I really want to do is spend some time talking, that song from Hamilton about it happened in the room. We're going to talk a little bit about what it's actually like to be in when someone chooses medical aided dying. Because I think that that's where a lot of myth and angst is. And there's also a lot of stuff about what it might be like. And I think it might be helpful for people to hear about that. But very informal. So please interrupt, ask questions, give your perspectives. I know that there's a lot of different experience around the table and on the screen. And some people who've had even more experience, and everybody has a lot to. So feel free. So first of all, the issue of why is talking about death a taboo topic? I don't know, but it is. And no, I don't know. It seems to have been for many centuries that talking about death was not common. Planning for death was not very common. And it became this issue of people becoming very, very uncomfortable. Some of you remember our dear friend Ellen, the blessing. And I will never forget when she died in 2007. Those of you who were at one of the minion services at her house will remember that her very close friend read a piece that used all the euphemisms. And she said, well, we say, well, we lost Ellen. And she said, well, I didn't lose her. I knew where she was. Or Ellen passed. And she would say, well, she didn't pass. And,
it's very hard to hear.
Oh, sorry.
For Zoom, it's hard to hear you, Barbara.
Yeah.
Okay. Is that any better?
Yes.
Okay, sorry. So I was just talking about why we use all these euphemisms. She passed, she died, we lost her. And it just shows that we are, I think, extremely uncomfortable still using these words because they represent something that we're uncomfortable with. And I think over time, and I think Cindy and others have had a lot of experience at the bedside, we're trying to demystify the whole thing and make the conversation more comfortable. And that's not the particular topic tonight, but I think it's why then when we talk about medical aid and dying and our choice to maybe utilize that, it becomes even more taboo because we don't understand it and we don't understand the choice. And I want to make sure that we understand that medical aid in dying is a choice and it's a tool in the toolbox of end-of-life care. And I think that's really important because sometimes we get narrowed down into this focus about medical aid in dying. And then people think, oh, well, if I can't do that, then I can't have a good death or a dignified death. And I just want you to know, at least my perspective, is that that's not the case. Medical aid in dying is one tool we have that is very important for some people, but not for everybody. And for those of you on Zoom, I apologize. I'll send you this link at some point. I think I have enough for those here. This is a document from the state of Colorado. And that I have the risk that you'll look at it while we're talking, but it talks about the issues of what it is to make healthcare decisions. And I guess I probably don't have enough, but I'll let you pass those.
No, we
and then
don't.
we can get more. Okay. And I want everyone to understand that medical aid in dying is in the context of choosing what you would want for your care should you be faced with a terminal illness that where there was no hope of recovery and where you wanted to have control over your dying. That's really what it's about. And so there are many ways to have a peaceful and dignified death, in my opinion, and medical aid in dying can be one of those. But I think it's just important not to think that it's the only way, because sometimes it's not appropriate and sometimes we can't use that mechanism. And then we don't want people to feel bereft and if there's no other choice for them. Does that make sense? So I'm hoping that most people are at least a little familiar with the concept of talking with family and friends and loved ones about your wishes, in particular, talking about living wills and durable power of attorney for healthcare. Does that ring a bell for most people, I hope? Most people on Zoom? Oh, hi, Karen Bennett. I look up, oh, and Scott Lordich, I look up and there are all these new people. Hi, everybody. So I hope that also rings a bell for most people on Zoom. If you don't have those documents, I'm here to encourage you to have the conversation with your loved ones is the most important thing. And then if you can, to do the documents. I think it's really important. Any questions about those documents before we dive into medical aid in dying itself?
Is medical aid in dying part of one of these documents that?
Good question. No. So the documents that are in here in particular are living wills and power of attorney for healthcare. A living will, and I'd like to clarify this, really applies if you have a terminal illness. And the reason I want you to remember that is if you have wishes about your health care, like if you're in a horrible car accident or you have COVID or whatever, a living will actually doesn't apply. A lot of my patients say to me, well, honey, I have a living will, and I've also picked up my plot. I'm all set. Not necessarily. The companion piece is the durable power of attorney for healthcare, which allows you to appoint someone to make decisions for you if you can't make decisions for yourself. And so if you're interested in medical aid in dying, we'll get to this in a minute. One of the things you have to have is decisional capacity. So you're making that decision at the time. Now, you can certainly express to your loved ones ahead of time that that might be your wish, so they're not surprised when you might go down that path, right? But it's not something that goes into one of these documents. And I think that's really important. The other thing about the power of attorney that's really important, hang on one second, Cindy, sorry, is that we go through this with families a lot. Well, I'm their power of attorney. I can make this decision. Well, really important. And that doesn't go into effect until or unless you are without decisional capacity yourself. So your adult child, no matter how wonderful and well-meaning they are, can't blast into the hospital and start making decisions for you if you are able to make decisions for yourself. What was your question?
So if you can't make decisions for yourself and you've designated someone to make the decision for you, can they make the decision?
For medical aid in dying? No, because if you can't make decisions for yourself, you don't qualify under the statute. Good question.
Even if you.
told them before, correct. And we'll talk, it's a very good and important question. And in the US right now, it's particularly important because in the 11 jurisdictions that have a law, every single one of them requires the person to be able to take the medication and to have decisional capacity. There's a lot of conversation about that, though. It's a good question.
I have a question about the 11 jurisdictions. I know in Colorado, it's like a 15-day period from the day you first have an appointment or declare.
Right.
Is it the same waiting period in every state?
Really good question. And we'll talk specifically about Colorado in just a minute.
Yeah.
No, and there's a lot of movement towards understanding that the 2-week waiting period is very onerous for some patients.
Yeah.
And so in California, they are trying to change that, and I'm going to get some of these wrong. And they have in Oregon, they can override the waiting period if it's urgent. New Mexico's law was passed the most recently, and it's the most, I guess, liberal, if there is such a word. But there's very little waiting period. There are very many fewer restrictions in the New Mexico law. So it is different from state to state. This is not a federal law. These are state laws at the moment, and we don't know if that will stay forever. So
going back to designating somebody,
mhm,
I had filled out the 5 wishes.
yes.
And then I had a will,
Mhm,
and I had to destroy the 5 wishes because some of the questions in the will, there would have been confusion in which one do you use. So that if somebody's having a will drawn up and you have the 5 wishes, you might want to check with. the
You want to make sure they're
attorney.
consistent, but you should be able to combine
Yeah.
those things. So for those of you who don't know, the 5 wishes is a document that you can Google, and now it's copyrighted. You have to pay a little bit to get it. It's a nice, I like it. Some people don't like it. It goes through in much more detail than the living will, what your wishes might be. Like, if I had a stroke and I couldn't eat, this is what I would want. If I had a heart attack and I couldn't breathe well, you know, so it goes, if you've done it in real detail. So some people really like that. Other people think it's, I don't know, too specific, too confining. I'll tell you that my personal experience, both family-wise and with patients and their families, is that the more we are able to break these taboos, not just about medicating dying, but all these issues, and talk with our loved ones about their wishes. My experience is the better it is for everybody, most importantly for you, but also for your family. Because if something happens to you, and this happened in COVID quite a bit, and it's very sudden and a lot of decisions have to be made. If you can hear your family member's voice in your ear, you know, mom said, I don't want this, or my mom, who wanted to live forever, made it a little hard. But if you can hear your family member's voice, it makes the burden of making these decisions a little smidge easier, because you know you're respecting their decisions. So I think that conversation is really important. And there's no paperwork that can ever cover everything that would happen. And so it's a lot about what we perceive would be a quality of life that we would accept, and many things like that. Welcome.
Thank you.
So I don't know if this is premature, but so there's these other states, and various states have various laws.
Right.
So can you just go to another state? and-
Great question. I was just talking about this. So each state has its own rules. Most states have a residency requirement, as does Colorado has one. Those laws are now being challenged as being unconstitutional. And the recent lawsuit in Oregon, there was a physician and patient suing to say this wasn't fair because the border, Oregon, Washington, Idaho, et cetera. And so now they don't have a residency requirement in Oregon anymore. Vermont suit just was one in favor of those, saying there shouldn't be a residency requirement. So those requirements are falling. But we'll talk more about Colorado since we live here. Other general questions before I talk about what is medical aid in dying, and then about the Colorado statute? Anybody on Zoom? Everybody's good? Hey, Tara. Are you raising your hand or saying hello?
That's.
Oh, that's you.
my
That's
turn.
your hand. Okay, Rabbi Jamie's saying hello. That's good.
So when you, and I know a lot of people might have this concern, as I do, if you need to have that capability of making that decision, how does Alzheimer's factor in?
There we go. Okay, another conversation. Can I answer that in a little bit?
You bet.
Or try to answer?
You bet.
You know, when my kids were little, you've all heard me say this. We'd be driving and Evan and his friend would be in the car, and he'd ask me a question and I'd say, that's a good question. And he would turn to his friend and he'd say, that means she doesn't know the answer. So we will come back to that. Okay. There you go. Seriously. So first of all, let's clarify what medical aid in dying is.
Barbara, just maybe, on your first question,
Yes.
why is this a taboo?
Yes.
Just to acknowledge that death presents an unknown to us. And, in our tradition, acknowledges that and doesn't try to insert, oh, we know exactly what happens after we die. And anything that there's an unknown about creates fear, right? A lack of control, lack of certainty. And so just to, if any part of this conversation is uncomfortable, don't be shy to excuse yourself, or, the bathrooms around the corner. Just to take care of yourself as you talk about, death is not easy.
Thank you. Yeah, thank you. And ask more questions. So First of all, medical aid in dying is a way that those persons with a terminal illness with a prognosis of 6 months or less can take control of their dying process and decide that their suffering and their quality of life is no longer what they want, and they understand that it would continue to decline, and they want to have control over their dying, the place of their dying, the time, the method. So medical aid in dying is a way to allow those patients who have decisional capacity to use medication that needs to be self-administered to take control of the timing of their death and many of the details around death. Medical aid in dying is not suicide. It's not assisted suicide. Our laws are very specific in naming it as medical aid in dying, and there's a lot of reason for that. So when a person dies after having used medical aid in dying, they die of their illness. And I think that's really important to remember, because as families are talking about what mom or dad or brother or sister or friend are going to do, I think the language is really important to understand, to help families understand what's going on, and to help families respect another person's wishes. And that doesn't mean that it's easy. Those of us who've been at the bedside know that, but it makes it understandable. It helps families to know that they're helping their family member do what they want to do. So that's what medical aid in dying is. There have been some versions of medical aid in dying that you might have heard about in the past. Jack Kevorkian, which, he doesn't have the best legacy in some ways, but in other ways, he kind of started this movement, which was to say that we should have autonomy, over our final days, et cetera. And then there was, the Hemlock Society, which transformed over time into different organizations. And this movement towards having this be, a medically supervised process, and kind of take it out of the taboo topics and bring it into, an accepted and recognized mechanism that patients can use. For the initial medical aid in dying, you might have heard of secobarbital. Some of you have heard of that. It's a barbiturate medication that before my time, for sure, people would stockpile secobarbital, in their medicine cabinet and take enough to die. It didn't work that well. It took a long time. And a number of years ago, it became extremely expensive, like thousands of dollars. And so in the past few years, there's been a lot of work on the actual medications that we use, which we can talk about if you're interested. And also there's been a lot of work done to make sure that patients who can't take medications orally have other ways in which the medications can be administered. That is an option for patients to either take the medication orally. Medication can be administered rectally or through like a tube in the stomach. And so that's helped broaden the reach for patients who had reasons why they couldn't drink the medication. Okay. So basically, medical aid in dying is a way in which patients who qualify, different from state to state, can choose to go through the process, have the prescription, choose the date and the time, and who they want to be there. So what does that mean? Do all patients who go through the process end up taking the medication? Probably won't surprise you if the answer to that is no. For many reasons, patients go through the process and feel tremendous relief that they have control over their situation, usually in situations where they have little control over anything else, like their disease. And there's a lot of comfort in knowing that if their suffering becomes unbearable, they will be able to use the medication. About 30 to 35% of patients who are qualified, meaning they go through the whole process, will end up not actually using the medication. So I think that's just very interesting to know. And
What was the percentage of people that
don't? About 30 to 35%. Yeah. And it's for many different reasons. Sometimes they get too sick, sometimes they lose decisional capacity, and sometimes they just decide it's not what they want to do. So that's what medical aid in dying is, in like that's a cliff note. I want to talk about the Colorado law, and then we'll talk about what it's really like in the room. But are there questions about what medical aid in dying is?
I have one question. So if you do this, are you still able to be an organ donor?
Very good question. Could you hear? Yeah. So the question was, if you take the medication for medical aid in dying, can you still be an organ donor? And the answer is yes, depending on, as many things, depending on the situation and what your underlying illness is, and what might be useful. I mean, that's kind of a crass way to say it, but you know, organ donation has changed so much. There's so much more of us that we can donate. And so that's definitely possible. Yeah. Other questions?
It's not exactly about what is medical aid in dying, but do all states call it that, or do some call it assisted suicide or other things?
Another really good question. I've read most of the statutes, but they get, after a while, they like go crazy. Most of the states call it medical aid in dying. Some of the state statutes are called death with dignity. And a lot of people who are involved with this process in one way or another do use the phrase death with dignity. My mentor and friend, Lonnie Shavelson, who's a physician who's been involved for a long time and is kind of a leader, he gives a wonderful talk about what I was talking about at the beginning, about why he doesn't like to use the terms interchangeably, because he doesn't want anyone to feel like if they don't use medical aid in dying, they're not having a dignified death, right? So that's where there's a little bit of just, I don't know if it's semantic, but it's important. So hopefully we can do a better job in the US with more dignified death, whether it's through medical aid in dying or other ways of providing end-of-life care. Yeah.
So the medical aid in dying is one option among the many that offer dignity in dying.
Exactly. Exactly. And I think it's really important.
Are you going to talk about those other options?
I'd be happy to. I mean, yeah. Why don't we go through the statute a little bit, what's like, and then we can talk a little bit about that. Okay. Other questions about the medication or medical aid in dying as a process? Because we'll talk about the nitty-gritty in a minute. So in Colorado, how many of you have been here for quite a while? I know a lot of people on the screen have been since at least 2016, 17, almost everyone. No, when did you move here?
7 months ago.
7 months ago. Where'd you come from?
Louisiana.
Oh, okay. Well, you don't have.
New Orleans.
Oh, New Orleans. Thank you. So you don't, Louisiana does not have a statute. Okay, so this might be all news to you. Those
Use fried chicken as our.
I see. All right, I appreciate that.
No, just a second.
There you go. In 20, I don't know, 2015, 14, 16, there was a lot of work in Colorado to pass a statute. The legislature could not get it together to pass it. And so it was actually, Ruth, help, I'm losing the word. We all voted for it. Okay. So that's different. In a lot of states, it's just passed in the state legislature. And so the statute, and I was not involved at that time, I have to tell you, really at all. I was practicing geriatrics, end-of-life care. I was very supportive of the philosophy and the idea, but I was not involved in any organizations or any of that stuff, lobbying. Statute passed in 2016. A lot of people did a lot of work. It went into effect in 2017, which is now quite a few years ago. And, you know, as with many places, it turns out we just have a lot of work to do. Those people who were exhausted having gotten the statute passed, I think kind of thought, okay, it's passed. And so now we can like stop working. And so we are now reinvigorating the process of making sure that Coloradans have access and information about the statute, because I think it's really important. And we know that there's a lack of education, lack of access around the state, including in particular among physicians, by the way. So our statute follows the statutes of many states. So you have to be terminally ill. That has to be confirmed by two physicians and someone who will serve as your attending physician and a consulting physician. Doesn't have to be your specialist or your oncologist, by the way. So two physicians have to confirm that you have a terminal illness and that you have the capacity or the ability to make a decision about something like this. So that's really important. You have to have decisional capacity to participate. You have to be a resident of Colorado, which is defined in a kind of interesting way that I'll get to. And then you have to do two verbal requests. Now, see if you can track this. Gets people crazy. Two verbal requests and a written request. And the verbal requests have to be separated by 15 days. And those requirements, I think, were put into the law for guardrails, which are reasonable in many situations, but not in all. And some of the criticisms are that it's just too cumbersome, that for patients who are really suffering and have waited, it's too long. 2 weeks can be a long time. And there have been some other criticisms of our law. Our law requires that the prescription be written by the attending physician, cannot be written by a nurse practitioner or a physician's assistant, which in rural parts of the state can be an issue. And I said the written request, I hope, did I?
Yeah.
Okay, and the written request has to be witnessed and it can't be by this or that or another, so it's got some legalese in it. Again, intended to safeguard everyone, but sometimes gets a little bit cumbersome for patients. So those are the requirements. It's also required that the attending physician and the consulting physician note that the patient is not being coerced, that the patient is able to self-administer the medication. So unlike Canada and some European countries, particularly Switzerland, we don't have the ability to administer medication in an IV or to give the physician can't administer the medication, nor can the family. And again, there's a lot of debate about what is self-administration. Family members and those attending death can assist with mixing of medications, holding a cup, holding a catheter if it's going to be a rectal administration. So there's a lot of questions about that often. But that's what our state statute is. The residency requirement.
You mentioned 6 months.
And 6 months, yes. Now, those of you who have either been through these kind of illnesses or are medical or just whatever know that our ability to prognosticate in medicine is pretty bad. And I don't make fun of that, but we just have to do our best. And so it requires, two competent physicians to say, in my best estimation, the prognosis without further treatment like chemotherapy or something like that will be 6 months or less. We have many patients who make it past 6 months. And one of the questions you'll ask me is what happens if you get qualified and then you live for 8 months? There's nothing in the statute that prevents you from still being qualified if you exceed that prognosis, which I think is kind of good, actually, right? We make our best estimation. We're not always right. So about what's going to happen. So that's the prognosis part. And the thing about getting qualified basically means that you've gone through all the steps, and then it's really up to you, your family, and we like for of course, the clinician to be involved till the time you actually decide to take the medication. Interestingly enough, the law does not delineate that at all. Basically, you get qualified, you could get the prescription. I could say, see ya. I don't practice that way, and most of my colleagues don't practice that way for a lot of reasons. But the law doesn't say anything much past when you get qualified. I think some years ago, physicians were actually even writing prescriptions and pharmacists were filling the prescription way before a patient might want to take the medication. We highly discourage that now for many reasons. We don't want these are lethal medications. We don't want them in people's homes. Medications expire, they're very expensive. So we really discourage that practice. The other thing is that clinical circumstances change, and as some of us know from some experience recently, and so it's very important for the clinician to know a few days ahead of time whether any so-called red flag things have come up that would make using medical aid in dying a problem, or we would have to do something different, like someone who can no longer swallow might need to use a different route. So it's very important, I believe, that the attending physician stay involved with the family and the patient until things are decided and so forth. So that's a lot. And I'll get to some of those other questions in a second and talk about what's actually like. Questions about that, Judy?
What about, you alluded to it, but if you can't do it yourself, what happens to people like with ALS or?
Great question. The question from Judy was, what if you can't do it by yourself? Especially patients like ALS, which you've probably read about. I told you about Dr. Shavelson, who's worked with a lot of neurologic end-of-life situation, particularly ALS, and they recently sued the state of California, saying that ALS patients were being discriminated against, and it didn't fit with the ADA laws, because if they couldn't use their hand or some other mechanism, then they weren't being able to avail themselves of medical aid in dying. So of course, those of us who believe in this philosophy were like, you go. They lost that suit. The patient chose, actually, who was involved in that suit, she chose to end her life earlier than she would have, because she was worried that her last remaining ability would be gone. It's a very powerful story, really. So it's a very compelling question. There are some mechanisms that we can use where we can show in good faith that the patient is administering. There's nothing that says we can't help patients administer, right? So if you like for rectal administration, we use a catheter and the patient has to push the plunger. So, a family member or a clinician can hold the syringe, and patient can put their hand on the syringe as long as they're pushing, then a family member or clinician can help push. So with oral administration, patients have to be able to swallow. I mean, that we can't, get around, but a family member can hold the cup. It can be through a straw. And those patients who have feeding tubes already in place, there are some very ingenious engineers out there, Ken, who have figured out ways to rig it up so that like a patient can, this is particularly ALS patients, where if they just turn on the valve, then that's considered self-administration. It goes through the tubes and stuff. So there are some really compassionate ways to help patients and families, still staying within the law. The residency requirements in Colorado are kind of interesting, because the first few times I have to keep pulling out the statute. Basically it says you have to own property, lease property, and show that you have like a gas bill or a driver's license, ID.
Yeah.
So it's kind of interesting. The law was intended to protect and say, we're going to do this for our residents, but those are pretty loose, right? Like if you own a home in Summit that you use as an Airbnb and you live on the East Coast and never ever come to your condo, we've had a couple of patients like that. So it's not totally loose, but it's, we have had many patients come to Colorado for family or other reasons and establish residency by one of these criteria. And so each state has its own residency requirements. They're different from state to state. It doesn't say that you have to live here for any period of time. At least that's not my reading of it. So
In Colorado?
in
it
Colorado.
doesn't? So we
Mhm.
don't have a solid residency?
Well, we do. I think the intent is different than how it's written up personally. The intent was really for people like us. We live here. We're Coloradans. The law was written by Coloradans for us. I mean, to be whatever about it. However, the way the legalese is, gives a fair amount of wiggle room, I would say. Yeah.
Who oversees the regulations? Who is trying to say reviews this? And is there any danger of political inroads into that people?
Well, I obviously got caught in some political and religious.
I'm
Crossfire.
curious to know, I don't know your story. I
Okay.
am curious to know.
Yeah, I will tell you, I'll tell everybody in a second, but, you know, this is regulated by the Division of DORA, which is Division of Regulatory Affairs. So they regulate like everybody, like barbers, nurses, doctors, nail salons, like everybody with professional licenses. And they didn't put out separate regulations from the statute. We do have to, there are certain steps you have to take. The attending physician has to submit a report after a patient dies. The pharmacist has to submit a report. And you have to keep, we don't have to submit the documents, but you have to obviously have them like you would any medical record. I don't know of any instances where DORA came back, whether anything was ever challenged in these years. Could have happened, but I think we'd know.
Are they physicians on, regulatory boards? Sometimes they are. Other professionals. I know I've got.
Well, the medical board is physicians.
Oh.
Yeah. So I guess if it came to that, if there was a question, that's where it would go. Like if somebody in the public said, gee, I think something went haywire here. That's where it would go. As far as I know, that's not happened in Colorado. What has happened, that's a segue, and then we'll talk about what happens in the room, is in the state, our statute, because of what happened in some other states, our statute says that healthcare systems can opt out of patients making use of medical aid and dying for patients who intend to use that process in their facilities. And that sentence was added because in other states, it was an opt-out, a general opt-out. And what happened,
Would you explain that a little more?
the opt-out or?
Yeah, what were you saying that?
So what was added in Colorado was a phrase that says they could only opt out for patients who say were in the hospital and wanted to use medical aid and dying in their facility. Okay. Now, as you can imagine, that's extremely rare, almost never happens. People want to be at home. So what happened was when the statute was passed in Colorado, the faith-based organizations, so that's like Centura, SCL, which is now Intermountain Health, which is a whole different story, but at the time, SCL, Sisters of Charity, and a couple of others, non-faith-based or big organizations just said, we're not going to do it. And they made these broad policies, including Centura, where I was working at the time. And the policy was that not only would they not allow patients to make use of medical aid and dying in their facilities, but that no employed or affiliated physician could participate in the process in any way. And I thought that was a very broad interpretation of the law. And we had patients who wanted to make use of medical aid and dying. And ultimately, a patient who had a very rapid terminal illness who wanted to stay within the Centura system and wanted us to assist him, he and I challenged the Centura policy. And 5 days after we filed suit to ask the court to look at the policy, I was fired. So that's how I got caught in crosshairs. So, and the rest of the legal story is
Wow.
long. So the point I want to get at is whoever asked about politics is the way the law has been interpreted in the state is variable. There's a huge market for faith-based systems, and these systems now employ many of our physicians, as you know. And so I counsel people, and I counsel all of you, if you're interested, to find out what your doctor and health system is doing, so that if you ever want to choose this, you can at least know whether your physician is going to support you in your wishes. That's what I counsel at the moment.
So I have my father just died through medical aid and dying in March.
Oh, here in Colorado?
Here in Colorado, and just about everything you touched on, I can relate to or experience from a one angle or another, but my father had Kaiser.
Mhm.
So I only understand it from the perspective of going through all of the steps that Kaiser requires. So I'm curious to know, are there lots of private practice doctors? Because I know that Denver Health has
Mhm.
a program and Kaiser does, and I believe there are private practice doctors, but it's a lot more costly.
Well, that depends, as most things. So yes, so this health systems that didn't opt out. Let me rephrase that. It was one of those active things, like if you opted out, you have to have a policy, you're supposed to notify patients. So there's lots of situations where people didn't opt out, but they're still not providing the service. Not because they don't want to, but because they need some help and some coaching.
Yeah.
So Kaiser has a program, Denver Health has a program, as you said. University of Colorado Health System did not opt out, and they have many wonderful people there, but they don't have a very organized program working on it. And then there are those of us who are practicing in the community who have had the experience and the skill to help patients. And so we're working on it. Okay. And we're working on it, trying to make it less complex for families.
Yeah.
Because at a time when your family member's making this decision, your family member's asking you to do the detective work because they're sick. And it's been very hard on families. And one of our goals through our new organization is to help families get through that. So the answer is yes, there are private people who are helping with this work. We are hoping to find more of those. We're also hoping to help educate primary care physicians and oncologists so that even if they don't want to learn or have some reason why they personally don't want to assist, that they have enough information to counsel patients and families and to be able to refer them appropriately without putting up a lot of barriers, right? I'll give you an example from today. I had someone who contacted me. She wanted to know if the new PCP she was going to see would help her if her cancer returned. And I said, well, I don't know this person. I'd kind of like to know. Would it be okay if I call him before you even see him? Sure, why not? So I called this person, this physician, and, had a really good conversation. And he said, I just moved here. I don't know much about this law, but I don't have any underlying reason why I wouldn't support her. I wouldn't prescribe myself because I don't feel comfortable, but I would help her. I would call you, I would, stay with her and respect her wishes. And so that's a really big deal for patients. And she ultimately saw this doctor and felt really good about it. So she's not upset that he won't do it,
Right.
because he's respectful of her, right? Big difference.
And so there's the physician, there's the hospital system. Can you talk about insurance?
Oh, thank you. Yes.
Advanced
Oh, thank you.
questions.
Yeah. I'll talk about, I'll talk about insurance first, but then I need to talk about hospice, because I kind of skipped over that and support. Well, in some states, Medi-Cal in California actually is now covering medical aid and dying. I don't know of any other Medicaid programs that cover. Medicare does not cover. And I don't know of any commercial insurances that cover. So we deal with that in a variety of ways. So the medication costs several $100s or more now. And, for patients in need, there are a variety of mechanisms we're working on. So most patients pay out of pocket for that. And then depending on the health system, we can still do a lot of the pre-work under the process of advanced care planning and conversation. But at places like Centura, you can't even do very much of that. And so then the patients come out of those systems and are paying out of pocket. There are some volunteer physicians who will do the work for no fee. So it goes both ways. So it is complicated, I think. To back up, I should have said before that part of the whole advanced care planning and care of end of life and terminal illness is hospice care. And the current best practice is for essentially all patients who are considering medical aid and dying to have hospice services in place. And that is incredibly important. Patients and families need to be supported by all the incredible things that hospice care provides. And again, medical aid and dying is a tool as part of end of life care. So why am I telling you this whole thing? Because there's a federal law from 1997 about assisted suicide that prevents any federal dollars from being spent on so-called assisted suicide. And so, because most hospices, of course, get all their money from Medicare, which is federal money, there's been a broad spectrum of how hospices respond to helping patients.
What?
Sorry. Yeah.
I want to talk to you so much after this about all of this too.
Okay, good. We have all this. Okay, so this is not a session all about hospice, but just to say the hospices have been under incredible pressure and they've dealt with it in many different ways. So many hospices, and we have many in Colorado that we work with, have figured out a way to support patients and their families to get through it, but to have policies that they think protect frankly, to protect their money. They don't want to be sanctioned by Medicare. And so they have policies where, like, the most recent when I was at, the nurse came, she had to sit in the living room. Some of the hospices say the nurse can't be in the home until the patient dies. Some of the hospices are like, pardon me, screw this, and the nurse is in there. So, it depends on their level of risk, how their risk tolerance. So we're really working with hospices to make sure that potential clients understand where they are in that process. So you or your family wants to have a hospice that's going to be basically supportive. They may not mix the medicine or help, hold the syringe, but if they're going to be supportive and helpful before and after, that's what we're looking for, I think. So, yeah, it's a big deal. That's a really big deal. Is there a question?
Crispin mentioned that Medicaid is now covering it in New Mexico.
Oh, thanks, Crispin. I didn't see you were there. Hi, Crispin. Crispin's on our board as well. So that's hospice. Other questions before we kind of talk a little nitty gritty and then we'll kind of wrap.
There's another question about, there's how to cover it for people who in need, financial need, and also Anne mentioned, what about proof of residency for those who are unhoused?
Oh, yeah. Thanks, Anne. It's a good question. Well, unhoused, Denver Health and their coordinator there, Katie Sue, they've been doing a lot of work on this, both for people from out of state and also people who are experiencing homelessness. And in some ways, I'm not going to say that's easier, but we have found, believe it or not, some Airbnbs where they are letting patients come. And patients and families tend to want to not be secretive. They don't want to go do this behind a closed door. We don't usually recommend motels and that kind of thing. So, someone who's experiencing homelessness, but is a Colorado resident, is in some ways, if we can find an appropriate place, is in some ways a little easier, actually. Not easy, but a little easier. So there are options for people like that. There's a place, I'm blanking on the name, Ruth or Crispin or Cindy might help me, where they particularly are doing short-term leases for patients who are considering using Mechlin dying and either have been experiencing homelessness or coming from out of state. So it's kind of interesting, I think. The other question was about people who need help financially. Was that?
Well, I just added the homelessness question to the
Yeah.
short statement.
And so one of our goals in our new organization is to develop a fund. Denver Health has one. So that we can, if necessary, have some resources for patients who can't afford either if there are provider bills or usually it's going to be more the medication.
And Angela asked about the VA, which I'm assuming because it's federal.
Thanks, yeah. You'd have to go outside the VA system.
You can't
That
even
could
have a
change.
conversation in a building that.
Yeah.
We weren't even allowed to.
Right. Yeah, what can I say? We hope there'll be a tipping point. I mean, a lot of this will change. I've learned a lot, unfortunately, about the legal system in the past 3.5 years. And one of the things I kept saying to my attorneys was, I don't get it. The contract, the ethical and religious directives say you can't participate in assisted death, assisted suicide. And the Colorado statute is actually very clear. The statute actually says that medical aid in dying is not assisted suicide. But the attorneys were just kind of like, well, it is. So what can I say? It's been great. So let's just talk a little bit about what actually happens, and then we can have more questions and conversation. Before I do that, I'm not here to advertise our new organization, but I am kind of. So, what the heck, right? So this is End of Life Options Colorado. I say we're the siblings of the end of life organizations in the other states, and we model ourselves and hope someday to grow up to be like them. Seriously. Those of you who are on the Zoom, you could put in the chat if you want, Jamie, the website. We have a contact us page. You can contact us. We'll be doing more and more education. We have a resource page with some names of clinicians who are already willing to be contacted. For a long time, speaking of taboos, if we'd put this website up 5 years ago, we wouldn't have gotten anybody to say, yeah, put my name up there. So we're actually making quite a bit of progress, I think. We have a lot of work to do. And so we're getting ourselves organized. Okay, so what's it really like in the room? I would say that for the situations that I've been honored to be part of, you might be surprised to hear how, I guess as with many things in life, with the right preparation and the right understanding, how well things can go. So in the best of circumstances, all the paperwork, all the hassle, the witnessing, the residency is in the past. All that's been taken care of, the plans in place. The patient or the family's contacted the attending physician and said, I've chosen my date. The prescription is taken care of. We use pharmacists who are very, very knowledgeable and who do a lot of education with the patient and the family. Most of us, including Denver Health and Kaiser, offer to have the physician or a clinician at the bedside. Not all families want that, but many do. So we set all that up ahead of time. We encourage it in case there's an unexpected something. We double check best practices to make sure that nothing new has happened, that some of these medical red flags that we worry about haven't occurred. Because what we want is things to be, as peaceful and calm and under control as possible, right? And so on the day of death, the patient has decided who they want to be there. Medication is in the home. The hospice nurse is either there or going to be there, depending on the hospice. And then in the situations where a clinician is there, the clinician might help with mixing the meds or might not if they've already been mixed, and is there really for support. For the families who feel confident and don't want one of us there, we're available for, to be called. And so basically, it's very peaceful, the family gathers, they do whatever last goodbyes and other rituals they want. It's all based on what the patient and the family want. And then there's preparation, and medication is administered by the patient with the help of usually of the family, either orally or by other methods. Most patients are deeply asleep within 3 to 5 minutes. It's quite amazing. And it's a very deep sleep. And then now with the formulations we're recommending, most patients, the average time to death is within 2 hours. There are some situations where the death is prolonged for reasons we don't always understand. And so we basically provide that preparation for patients ahead of time. For families, the patient is deeply asleep, and it's really supporting the family if it's going to be more prolonged. But I guess the thing I want to, it's hard to express, is how peaceful and respectful the process is. The most recent patient I was with, he had his family all around him, and he was annoyed because I was preparing the family in the other room, and he was like, "Come on, like, I'm ready. He's kind of irritated with me, but I like to prepare the family, and so we were all there, and he looked at his family, and we looked at all of them, and he said adios, and and I don't make light of that. It was really an amazing thing. It was so peaceful, and he was so sure, and most patients have thought about this for a long time and unafraid, and his, families, I think, do well understanding that and supporting it. So and then this particular patient died within 10 minutes, actually, which was really fast. But I think there are times when it doesn't go that smoothly, but most of the time it's very peaceful and very smooth. I was preparing his family, and there was an adult grandson, maybe in his 20s, and I was going through my routine. This is what happens if you've never been with someone who's died. I like to explain it. And I said, look, this is the average, but it could go on for hours, and you need to be prepared for that. And this young man, he said to me, well, does it ever not work? Another good question. So, you have to be able to answer those questions. So I was gratified that for this particular patient, he got his wish, and it went as smoothly as it did.
Does it ever not work?
I don't think it ever doesn't work, but it can have some complications, as any medical procedure. It can be longer than we expect. Patients, though they're deeply asleep, it can be, if you've ever been with someone who's taking their last breath for hours, it can be, there can be disturbing movements and sounds and so forth. So it's more the issue when it goes on for a long time.
So pharmaceutically, is it like a very big sleeping pill?
It's a combination of very potent medications. So it's a combination of morphine, Valium, amitriptyline, which has ill effects on the heart if you take it in really high doses. I'm missing one. Phenobarbital. So these are huge doses of medication. I mean, they are lethal doses. So we also have to be very respectful of those, right? In terms of, not leaving the medication around and that kind of thing. Okay, the Alzheimer's question, and then I'll answer more questions. There's a lot of work being done in general in the United States and a little bit in Colorado about the whole issue of cognitive impairment and the whole spectrum. And should patients with cognitive impairment and the non-cognitively impaired self make decisions for the future demented self? Think about that for a while. And these discussions are very intense at the moment, right? So there is no state where that's supported, just to let you know.
Is there any country where that's supported?
Yeah, you can go to Switzerland.
Okay.
You can go to Dignitas in Switzerland. Canada, not so much, I don't think.
Belgium?
I don't know about that. Portugal just passed a medical aid like this week, and I haven't read the law. Anyway, the point being that there's a lot of conversation about what that should look like. There are a lot of people who work in Alzheimer's and Alzheimer's type dementias who are extremely opposed to any idea that medical aid in dying would be used because of the whole, like, who's in control and is the person making the decision. And even if there are advanced directives now being written specifically for people with early cognitive impairment for what they want when they get more severe, just related to their wishes for their care in general. And this conversation is now coming into the whole medical aid in dying field, but right now there is no medical aid in dying anywhere for a diagnosis of dementia. Now, I will back up and say that there's a lot on the spectrum of cognitive impairment. And so there are patients who can have mild cognitive impairment and a terminal illness who are able to make a decision about medical aid in dying. So those folks are not excluded, right? Which I think is really important. There are who asked about the other approaches. So the other approaches, end-of-life care, are many. One of the more recently you may have read about or heard about is called VSED, which is voluntary stopping of eating and drinking. Have you heard of that?
Yes.
Yes, okay. So voluntary stopping of eating and drinking is interesting because, you know, in the US for a long time, we've had this whole thing about patient autonomy, right? So nobody can force you to have chemotherapy or, you know, radiation therapy or surgery or treat your blood pressure if you don't want to, or your cholesterol. You know, you have that choice, you have autonomy. And so part of that autonomy is that nobody can force you to eat or drink. Which is an interesting thing, actually, when you think about it. So there are some patients who, for whatever reasons, either they live in a state where there isn't medical aid in dying, they don't fit the exact criteria for medical aid in dying, or they have some sort of cognitive impairment, but not so much, and they choose what's called VSED, voluntary stopping of eating and drinking. There's now a new book out about this. And, you know, for some people, it may be the right option, although I will tell you that it's quite difficult because it's not just that we all like to eat and drink, I do, but, you know, as you start to become dehydrated more than really hungry, your body has this huge drive to drink. And so people have to be really strong in their belief and have to have family and staff if they're in a facility who will respect that wish, because when you start to ask for something to drink, you know, that's hard. I had a patient a number of years ago who decided to do this. She came back from the hospital and I walked into her room at Claremont Park in Ussery Hills, and there were signs up all over her room that said, "Please do not give me something to drink." It was in her handwriting. "Please don't give me anything to drink, even if I ask you." It's really hard for staff. But for many people, it can be very peaceful and it's what they choose. So that's one option where a patient really has to, you know, make some pretty serious decisions.
About how long does that take you?
It really depends on what the underlying illness is, how dehydrated and malnourished people are. Usually it's 10 to 14 days, could be a little longer. Thanks for coming.
Walking up into the topic, please. Thank you so much.
Thanks for coming. So it depends a lot. Yeah. And it can be faster if people are already underlying, you know, are quite fragile and ill to start with. But there are other approaches to end of life care that are really important. And it's mostly about making sure that it's a combination of patients' wishes and what the tools we have being respected. Okay, so what do I mean by that? Like, some of you have been with a family member maybe when they died, and, you know, some family members really want to be very alert and be able to be communicative towards the very end, and they don't want a lot of medication because they don't want to have their sensorium clouded. And so those patients might say, "It's okay, you know, I'm having pain," you know, hospice nurse might be offering more pain medicine, and the patient's like, "That's not what I want. I don't want to be, you know, basically sedated at the very end." There are other patients who, you know, have told you ahead of time, "I don't want pain. I don't want shortness of breath. Those are the symptoms I want you to control." And we have good medications and we have good ways to control symptoms. I'm not going to tell you that we can do that 100% of the time or control all symptoms, but we can do a really good job. And I always want patients to know that, particularly if we're in a situation where we have to say, well, for these reasons, medical aid in dying is not appropriate here. But we're not saying no to making sure that you have as best as possible the kind of death that you want. And that has to do with location and who's there and, you know, how much medication. So I think we have a lot of tools. I think they're usually used appropriately. The problem in the US is that we tend to be very late in hospice referrals, which is really a shame because hospice has a lot to offer. And when we get hospice involved in the last 24 hours, I mean, it's okay, but I think patients often haven't really gotten everything they could with hospice care.
And earlier, Jamie Bernstein asked a question about the Reconstructionist Jewish approach to this.
There you
And I'm also curious to hear, you know, because you have this conflict between the individual states and the federal around the ethics, in the medical community,
Yeah.
in terms of this, and there's a common value in, medical community and the Jewish law in terms of preservation of life, pikuach nefesh, as sort of the, preeminent value. And maybe you can start and.
Okay, I'll try. I mean, I think that, this is a difficult topic for physicians. However, I think that most physicians understand, especially when we have deep conversation, that it is the illness that is causing the death. And that is really, really important to remember, that and really the imperative to care for patients and do good and not harm is applied, and beneficence in medicine and autonomy, which are two of the main medical ethics. That's what we're doing when we respect patients' wishes in this regard. I also think it's what we're doing when I would tell you one of the hardest things I have to do is tell a patient that they don't meet the criteria, right? It's really hard. But I think we have to have high integrity about that. So I think that's how many physicians, and there are physicians whose personal religious beliefs, are like, I'm not going to do this no matter what. Those are expressed in a variety of ways. Systems have expressed it by just saying, well, we don't believe in it, so you don't either. More blanket. To the other spectrum, which is, well, I don't, this is not part of my belief in what I can practice, but I'm gonna, I respect you and your choice, and I'll help you, find that. And I think that's very important, that we can be respectful. There was a recent study, well, in 2016, when the law was up for vote, over almost 70% of Coloradans voted in favor of the statute. It was the highest percentage of any statute like that, ever in the history of Colorado or something. It's pretty amazing. Think about it for a minute. Yeah, it was amazing. So about a year ago, a group at UC Health, a research group, wanted to see what physicians in Colorado were thinking and doing. And their study is very interesting. 60 to 65% of the physicians that they queried said that they were supportive of the law and patients' rights to access the law, but only 25% of them felt comfortable actually helping the patient because of education. And like this gentleman I talked to about my patient, felt they had the skills and the knowledge. It wasn't because they didn't want to do it, because they didn't feel like they, were trained to do it. So that was really very telling to me, that the physician population actually really mirrors what the Colorado population was saying. I just think it's amazing in terms of support.
I feel like it circles back to the whole being comfortable with death and not viewing it as so taboo to talk about it. It shouldn't be.
And also a lot of responsibility. You can be supportive of something, but not
Right.
be responsible.
Would also want to do it. I think, hopefully physicians want to do what they do well in general, but this is a higher stakes.
Yeah.
Like this one, you don't want to mess up. Let's
Right.
be frank, right? Also with oncology, you've all heard stories, read the stories about particularly older patients, getting all these treatments they don't really want or aren't going to work. And, more and more work with making sure that, patients and families understand their choices. Like, if you don't want chemo, you don't have to have it, or you want to try it and then you want to stop, making sure that patients and their families are advocating so that it's not just like what the doctor wants. I think is really important.
And it's a unique medical procedure, because every other, procedure, success equals preserving life.
Right.
And in this case, success equals a death with dignity.
Yeah.
And to respond to Jamie's question about in the Reconstructionist movement, there's a strong consensus of support for these laws, states' laws, that are seeking to provide the option of medical aid in dying. And, you know, I don't want, this isn't a class about the Jewish medical ethics. But there's an essay on in reconstructing Judaism is the Reconstructionist institution movement, and there's a publication, an online publication called Evolve. So if you Google Evolve Reconstructing Judaism, Dr. David Teutsch, Rabbi Dr. David Teutsch has an essay, a piece on it. He's considered the expert in ethics in terms of the movement. And he talks about there are exceptions to this Jewish principle of pikuach nefesh, right? Everyone's taught like you can break the laws of Shabbat to save a life, of course. But there are also instances where you can sacrifice your life to preserve your dignity. You can relinquish your life to prevent being forced to commit idolatry. So putting dignity or kavod as a prominent value, one that supersedes even this, you know, a significant principle that is guiding much of Jewish law, is the foundation which the movement is supporting these initiatives, that a person's right to live and die with dignity enables one to even and we talked about this value of kavod when we talked about death and burial and tahara, right? The rituals between death and burial that we've been talking about this year. That dignity is the prominent value, and this is all about supporting and honoring the body and the soul.
I think it's so important because I think about these situations that I've been in with families and recently with friends. And I don't want anybody to leave here thinking that what happens in the room is fun or easy or without emotion. That's not what this is about. It's not. It's facing up to an inevitable situation and working through that in a way that patients and families can really get the dignity, and for families in particular. Okay, sums it up. It's like, you know, it's really important. It's not that these families aren't grieving deeply. A few of you were, yeah, really. A few of you were at our launch party where we had the daughter of one of my patients, and she was about 6 months out, which was probably good because it's hard, right, to talk about. And again, humor is helpful, and she was so great talking about what happened with her mom, and I think hearing in the future from people like that is really helpful. And at some point, maybe you'll share. If there aren't other questions, I was going to end with another poem. If we're good, are there other questions?
I just want to thank you for the work you're doing. It is such a beautiful and important cause, and you are helping so many families.
Thank you. Well, thank you.
I did have another question.
Okay.
Do you require, or do physicians in general, in order to administer the medication, do you require that the patient have people with them? What if they just want to be by themselves?
Oh, there we go. Another good question. Thank you. Require. No, we don't require. I would say I can't think of a circumstance where we've had a patient completely alone. There might be other states where there've been more. I don't know of a situation, but we do have patients. Like I said, I've had patients where the family was like, no, we're good. We got your phone, you know, we got you on speed dial, and we just want to be one person or a couple. I've actually never had someone ask to do it without anybody in the room. I could query our listserv and find out. There are a lot of, I won't get into all the legal problems, but one of the issues about hospice that's so wonderful is, and I don't know if you all know this, you know, if you die at home with home hospice, the hospice nurse comes, not 911, right? And it can be really a beautiful thing. They're very respectful, speaking of dignity. They do a lovely job, whether they're in the room at the time or not. They do a wonderful job. they call the coroner, they call the funeral home. It's really, really important. If a family member dies, or if anybody dies at home, without hospice in place, 911 gets called, the coroner has to make a decision. It's a mess. I mean, I hate to say that, but it is, even if it's a 98-year-old. That's another reason why we really encourage hospice at the end. Joanne. Hello.
Okay. I just wanted to share, you were talking a little about what's happening with dementia, and my mom had dementia, and her doctor knew that she did not want to live that way. She knew it really, really well. And when I went to talk to her, the doctor said, the problem now is she'd have to be lucid enough with 2 different doctors. She said, I would love to help and I can't. Because of the dementia, even though she had advanced directives and all of that. And she spent a year in a care center in a way that she would not have wanted to. And I just think that was heartbreaking. So I do hope that they are going to do some things around people making plans enough in advance that those will be honored, even if at the time you have dementia.
Yeah, well, I think, as I said, there's a lot of work, Joanne, and so sorry about your mom. May her memory be for a blessing. But I think that the other thing I counsel people about, whether you have a terminal illness or any other illness, is we all need an advocate. And I think that sometimes families really frankly, get kind of pushed around. So someone with dementia who develops another illness, the classic, pneumonia, someone who gets COVID, someone who breaks a hip, there are choices. And sometimes, I don't know, our medical system just gallops away, and we need, as family and loved ones, to say, not doing this. One of my first 2 COVID deaths was a couple that lived in assisted living. They were in their I think early 90s, and was way before vaccines and Paxlovid. And the granddaughter called me one day and said, Grandpa has COVID. And I was like, okay, luckily we had talked about it. And I said, okay. She said, yeah, can you do the hospice referral? Obviously we had talked about it enough. And I said, yeah, as long as this is what you and the family want, you've talked about it. And then the next day, the wife got COVID, and they died within days of each other, actually, at the assisted living. And the granddaughter, I think in part because we talked about it so much, was actually quite relieved. But in a lot of settings, because it was assisted living, et cetera, it's like out the door to the emergency room before the families even had a chance to take a deep breath. So, other questions?
How many people annually take advantage of this?
Oh, I knew the numbers, but now I don't. The numbers, do we have, how many people have taken?
Yeah.
We have it on the website. I don't have it in my brain.
And I would be close, but not.
Yeah.
So.
I think it will increase as the baby boomers.
Yes, yeah.
Is
Get
it
older.
dozens or
Oh, no, it's hundreds.
hundreds?
Yeah.
Thousands.
Yeah. No.
Does
200. Yeah.
Does End of Life Options Colorado have other professionals besides physicians, or is it all just all physicians?
No. Oh, thanks. Yeah, we have lots of incredible resources. So we have some nurse practitioners and physician assistants who can't do the prescribing or be the physicians, but can provide support on kind of both with resources. We'll soon be putting up a page with a group of folks, death doulas, who we haven't had a chance to talk about tonight, but as a whole, I think when Cindy did her presentation, she talked a lot about the role of death doulas. We are developing our volunteer base, and we'll be kind of expanding resources as we develop them. So we have some social workers, yes, and there we go. And rabbis, right. All right. So I'm happy to chat more, happy to chat about the parts of the lawsuit that you want to hear about.
Oh, no, I just am fast, like, I would love to talk to you about my experience.
Sure, okay, yeah, that'd be great. So, I was telling folks that before we started that the other night I really went down this rabbit hole, just so you know, there's a lot of poems about death. Anyway, this is by Rabbi Alan Mahler, you know him?
No, I don't know.
You know of him, okay,
But I know.
he writes poems. When I die, if you need to weep, cry for someone walking the street beside you. You can love me most by letting hands touch hands and souls touch souls. You can love me most by sharing your simchas and multiplying your mitzvot. You can love me most by letting me live in your eyes and not on your mind. And when you say Kaddish for me, remember what our Torah teaches. Love doesn't die, people do.
Nice.
Thank you all. For coming.
Aw.
Feel good.
Thank you. And again, our next one is next week. We had postponed this one, because of a death in the community and to this. So Rich Levine will be joining us 7:00 next Wednesday to talk about Second Amendment guns in America. Constitutional. Yeah. So thank you again. Thank you, Barbara. Fabulous. Thank you, everybody on Zoom. So glad you joined us.
Thank you.
Yeah.
Thank you, Barbara.
Thank you.
Thank you so much. It was a great presentation. We'd love to have that poem, that last poem.
Yeah, oh, okay, yes. I'll send it to you and you can. Okay, we'll send it out.
Yeah. Great presentation.
That's the version of the poem that was read at my aunt's funeral.
Oh, really? Because the
Yeah.
and I could very nice.
Poems to coming. The poems to be read at my funeral.
Oh, you're making a list?
I started.
Now that's.